So the first session, as I said, is going to be our panel talking about quality measurement. So we've got 4 speakers, Wendy Talbot, John Demore, Nance Shatskin, and Rochelle Fernandez. And basically the way it's going to work is that I'm going to pass it off to Wendy. They've got some slides. They're going to do their little presentation. If you've got any questions or anything that you need to ask, hold off. We're going to do it as, like I said, as a panel. So imagine the 4 of them are up on the stage sitting in comfy chairs, and we're going to pass the mic to them, and they're going to do their little spin to us, and then we'll have the break, and then we can ask the questions. Now, having said that, let's make sure we do have questions for them, because that would, you know, I'll be paying attention, and you guys all need to be paying attention. Let's ask some hard questions of them. So Wendy, you are up first. So I will, I don't know if I have to pass the ball to you, but I'll stop sharing. And then
I have a question before we go. Oh. Can we get the full slide deck posted? So we all have a collaborative slide deck.
You should have gotten it via email. Natasha sent it out.
Was that this morning?
Yes.
Okay, thank you. Appreciate it.
No worries. So Wendy, you are first. Do I have to make you? Oh, no, good. You can do it. You're good.
I think I should be sharing, correct?
Yep.
All right. Well, good morning. I'm Wendy Talbot. I'm the Assistant Vice President of Measure Collection and Audit at NCQA. And so I'm happy to be here today to talk a little bit about a data aggregator validation program that NCQA started. Actually, I think I talked at the Implementation-A-Thon back in like September of 2019. We had really just started the idea of kind of piloting this concept. And what it really is doing is taking a look at the use of C-CDA documents for HEDIS quality reporting. So just to kind of set the stage for those of you that might not be familiar with HEDIS, we have requirements where health plans who report HEDIS quality data to NCQA have to undergo an audit. And this diagram shows kind of the audit flow, the process of all the data that are considered when reporting HEDIS measures. The 2 categories that are in the red circle, the medical record review and the supplemental data, are really where the C-CDA documents have kind of come into play or use among health plans and vendors who support health plan reporting, that NCQA really started working on this data aggregator validation program for, because the C-CDA documents were coming with some quality issues related to the completeness of them, the accuracy of the data within them. And as health plans were trying to use them, it was causing increased burden on the audit process. So the problem that we were actually trying to solve as we kind of endeavored down the path of developing this program was the HEDIS audit is really plan-centric, which means a health plan has to undergo this audit every single year for every data source and data type that's being pushed forward for use in HEDIS reporting. That same plan might be using some of the same data as another plan, but the data results or the audit results are not transferable. They're not portable. So the auditor has to audit it every single time. And if you're a vendor who's aggregating data, you have to go through that every single time with them. So throughout the course of a HEDIS audit, a plan could be getting audited several times, the vendor could be getting audited several times, and it's a lot of burden to actually trace these data sources back to their point of origin. The continuity of care documents that were trying to be used during the audit, auditors were discovering that the quality of them was not always representing the source of truth, or actually what it was meaning to represent. And an easy example would be when they were doing this activity we call primary source verification. If they were looking at the C-CD and it was mammograms in there, when they traced it back to the original source, it was really an ordered mammogram. It wasn't a mammogram that was rendered. And so now you're pushing forward data to contribute to a quality metrics that really isn't what is being represented. So we did require this continual primary source verification of the C-CDs back to the point of origin, the EMR they came out of, which really was not facilitating the use of the data coming from aggregators in a more streamlined approach. So we really wanted to increase the access of these clinical data or the data coming from hubs such as HIEs, other types of data aggregators, to really allow for a more fluid use and passing of these C-CDA data. So we started in the fall of 2019 and developed a program kind of similar to our health plan HEDIS audit, but for data, clinical data hub aggregators, where we would, NCQA would take on the validation of the data at the aggregator from the ingestion point all the way through to the output. And that output is we created an NCQA C-CD implementation guide, which is a constraint on the C-CDA, the R2.1, where we took just those sections that were applicable to HEDIS quality measures to kind of put a different implementation guide or a smaller implementation guide together that these aggregators could conform to and that we could validate so that they could share them without additional need for audit. So really the program goals was to ensure that accuracy of the data from the ingestion point all the way through kind of that output exchange, as I mentioned. Could these aggregators conform to our NCQA CCD implementation guide for use as standard supplemental data, which means once it passed our validation, then the health plans who picked it up and used it for either HEDIS reporting or other types of reporting would not have to further undergo an audit by their auditor back to that primary source. This would minimize the need for audit at the vendor and the health plan level, and then really hopefully increase the confidence of the data used for value-based purchasing and other quality measure reporting. Some of the limitations in the program, or at least in the scope of the program as it was currently designed and being rolled out, some of the items that NCQA is not going to really get involved in is some of the consent arrangements and data privacy. We really are not going to take on any responsibility to make sure that vendors or health plans are following some of the consent or the state specific rules around data sharing. That's really between them to ensure that that's all being met. We're not looking at these data as measure compliant or from the quality metrics reporting perspective. We want to validate these data in a more agnostic way so that when they flow, they can be considered for any type of data reporting. And then the one area that we did not include in our implementation guide and kind of the review and validation process, at least in this first round, is medication data. Really, the purpose of that at this point is that most NCQA HEDIS measures require the actual dispensed event in order to count for a pharmacy-related measure. And we found that during some of our research discovery phases that the data that were being received by the aggregators and consolidated or aggregated into CCDs did not include that level of information. So we decided, kind of due to just the time constraints in developing the program, to kind of put a pin in that piece, and we will include that or incorporate that in future iterations. So just for those that are kind of visual in nature, this is really a graphic of what the program in its entirety somewhat looks like. So we've got all the way on the far left-hand side are the ingestion sites. So we worked with a couple of HIEs in the fall of 2020, most of 2020 actually, and any of them range from 250 to 450 plus ingestion sites. So the goal of the program was to validate the data from that ingestion through the inbounding, transforming of the data, kind of putting it into their data repository, all of that stuff, all the way through that outbound data transformation process, which was the outbound CCD. We follow the data kind of all the way through the process, and as part of that conformance checking with the CCD, can the aggregator conform to NCQA's CCD IG through a first process is a testing process through synthetic data files. Once the aggregator can conform to that, we then test that on real data. And then the real data, once it passes the conformance, we take a sample of that and then we trace that all the way back to that point of origin, which is those little blue arrows on the far left. And we do the primary source verification. So have the aggregator provide the actual screenshots from the EMR to ensure that they're truly matching what's in that output file. So an aggregator has to pass both of these. It's not a one or the other. They must go through both components in order to receive that validation seal. So where NCQA is at right now is, as I mentioned, we started the really kind of early conception back in the fall of 2019. Where we worked with actually the state of New York and some of the HIEs there to develop the program. So we did some discovery, went and met with some of them to find out what the pain points were. Obviously, we had talked to auditors, health plans, some of the requests, the needs around the ability to use the CCD files. So to date, we have developed the program and we've actually run 4 aggregators through it. So as of February of 2021, we have 4 aggregators, 3 in New York, 1 in California, who have passed the program, received the DAV seal, and can actually share the validated CCD data for HEDIS reporting for this current HEDIS cycle. We are now kind of in a phase where we are gearing up for a live launch of this program. And what we're really trying to focus on as we live launch this program and continue to enhance and mature it is really just continue to focus on that data quality and looking at, and John Demore's following up, and he kind of was helping us through the process of the pilot, and where can we further use data quality metrics to enhance and streamline validation steps. Because right now, as you heard, we are still tracing that data back kind of through a manual process to do that primary source verification activity. So we really want to be able to streamline those efforts through more of a data quality review and looking at that to make this process even more efficient than where we're at currently. We are continuing to do some market research to really see how we need to adapt and evolve the program. The program that we developed was very focused on true data aggregators, health information exchanges, entities structured like that, that truly kind of broadly grab data from, you know, outpatient clinics, hospitals, et cetera, aggregate that into these longitudinal CCDs or pictures of patient health. We also have a need for some of this to be adapted to just data exchangers. So they're not truly responsible from the legal aspect of those data and following it all the way through. So we're looking at the market to see are there needs that this program can address if we were to adapt and modify it. So we're excited to be targeting our live launch of this program in Q3 of 2021. Where we are currently enrolling, or not necessarily enrolling, but we're starting to keep a list of interested entities with the hopes to launch the application process here in May to really get started probably sometime mid-July to run the program. So with that, I'm actually going to pass over to John Demore, and he is the strategic advisor at Diameter Health, and he will talk to you about some more about the data aggregator program. So John, let me stop sharing. We'll pass it to you.
Thank you, Wendy. And let me see if I can share. So let me grab this and put this in presentation mode. Did that come up for everybody?
Yes. Yep, looks good.
Awesome. All right. So John Demore, I'm a founder of Diameter Health. I serve as a strategic advisor to the company now as well. You know, I'm going to start a little bit with the story, and then I'll back into talking more about Diameter Health and our work with some of the early data aggregator DAV Pilot sites that went through, and some of the ones that are actually validated to date for it. The story that I'm going to start with, and you know, full credit to Linda Michelson, because she was the one who I was talking with in the last couple of months for it, and she mentioned the story, and I was like, this is always a good one to start with. So. You have a little girl, or it can be a little boy. You know, we can do either gender for it. And you know, they have dinner one night, and there's a pot roast, and the ends of the pot roast are cut off because that's how her mother or his father prepared the actual dinner for it. And the little child asks, well, why do you cut off the ends of the pot roast before you cook it for it? And the parent says, well, that's the way that I always had done it, and that's the way I learned the recipe from my parent. And you go back to the grandmother or the grandfather, and you ask, well, you know, the little child asks, why did you teach, you know, my parent to cut off the ends of the pot roast for it? And the answer to that was, well, I don't really know, but that was actually the way that I was taught to do the pot roast by my mother. And you know, this is a very fortunate, you know, child, which is the great grandmother is still alive and in a nursing home, and gives a call to the great grandmother, and you know, is able to catch her and say, you know, why did you always cut the ends off of the pot roast before you cooked it? And she said, I think I remember our first house had a really small oven, and that was the only way that the pot roast could fit in the oven. And obviously the ovens are getting bigger over time, and there was no need to actually keep following that practice. But the power of tradition is really powerful, and doing things the way that they've been done before is you know, something that kind of falls into a lot of categories. And when you think about this process that NCQA is, I think, ushering forward, there's a lot of existing processes, there's a lot of existing policies, there's a lot of things that are already in play, because HEDIS, you know, has been going since the 1990s. this is not a new thing for the healthcare industry, for health plans nationally for it. And really, if you think back to when HEDIS got started as being one of the first ways to be able to measure quality, and now is used by virtually all health plans and is used by things like Medicare nationally to differentially reimburse Medicare Advantage plans that have higher quality. You know, HEDIS will feed into the STARS ratings for those plans, and they'll get paid more, they'll get big bonuses. And these are, you know, very large and material bonuses for those health plans. And the ones that don't do as well will get paid a lot less. When you think about the 1990s and even the 2000s when this program was started, you know, we remember what paper records looked like. You know, this was actually the way that, you know, health records were kept, legal medical records were kept for it. But as we've looked at the past decade, you know, a lot of the things, and we talked about the beginning of the Meaningful Use program was about the digitization of medical information for it. And, you know, it didn't happen overnight for it. You know, those prescription pads didn't go away overnight. And these big files and the doctor kind of appearing in the office visit with a chart didn't really disappear overnight, but it has vanished, you know, to a large extent now for it, which is this thing that people used to validate back to, this legal medical record, this paper chart, doesn't really exist the way that it used to anymore. And going back to the analogy, it's kind of like the ovens have changed. And yeah, we actually get probably a bigger oven now. We don't need to cut the ends off of the pot roast. And the reason why I told that story is because this is all around what the DAV program is thinking about, which is how do we adapt to a digital environment where we have information that's stored in electronic fashions and is transmitted to lots of different parties. You know, Wendy talked about those 200 to 400 different sources of that information for one particular validator. That's just a regional HIE. That's not even national for it. When you think about nationally, these are tens of thousands of different sources that can contribute information on patients. Now, obviously, not all patients will go to all providers, but when you're dealing with plans that have millions of members, this is a really tough problem. And to think about that reusability of how to make this program more consistent for validating data, you know, primary source verification today, you know, really can't go back to that paper chart to look at things. So, you know, Wendy talked about, you know, now we look at EHR screenshots for it, but there are ways to think about using the digital data because it's there to be able to facilitate this process. And it's an evolution. It's not a, you know, elimination of A to do B for it, but it's a change in the process. And I really think this DAV program that NCQA is leading is really part of that change for thinking about how to do this. So let's bring this to the context to C-CDA. You know, C-CDA is built off of CDA, and, you know, I've actually got the paper from Jamia from the early 2000s cited down here at the bottom for it. But when you think about CDA and what it was originally, you know, sought to do, there's a lot of attributes or principles that went into that. But one of the ones that I think is really applicable to today, because we're seeing this more and more, is the potential for authentication, which is, you know, CDA originally was meant to be able to be built for a way that you could actually say that this is something that is legally authenticated. This is as authenticated as the legal medical record. And we're increasingly seeing people who are interested in this, you know, getting fully signed notes within clinical documents, being able to get this digital data. And we're increasingly seeing that the validity of the data that's in that is getting better. I'm actually going to talk about a couple things that are really, really good, and also a couple things that we see that there's still a lot of opportunity for improvement around for it. But the reason why I kind of harken back to these original principles of CDA, which is we're at a real interesting convergence and I think changing time today, because the more that these constructs and these standards can become essentially as good of the source of truth as the original EHR, which I'm not going to pretend like they are right now, but I think that we're on a path towards that. Is that this can be something that can be accepted and really built into processes that are not necessarily subject to the full audit of kind of other non-standard sources in there. And the analogy that I use for this is sometimes billing data for HEDIS, which is, you know, billing data in the 1990s wasn't actually all that clean, and it didn't go electronic smoothly in 1 or 2 years for it. But over the course of many decades now, you know, you can't audit the billing data back to a HCFA form or a CMS form anymore. Those forms don't really exist, but we know that we have an incredible amount of confidence in how that information is flowing through the system and is feeding things, because obviously that billing and administrative data feeds HEDIS measures, and increasingly a large portion of HEDIS measures require this clinical information as well. So what did we actually do at Diameter Health? So just to say, what is Diameter Health? Diameter Health is a software vendor. We've been going through NCQA certification for their eCQM program now since 2016. And we work with health information exchanges nationally. We work with health plans nationally. We work with 3 of the top 10 health plans nationally in the United States. And increasingly, we're working with other people who want to use the data from clinical documents for a variety of different purposes. And we're seeing that increasing interest across industries. So we're working with life insurers now who want to use this information as well. One of the HIEs that we worked with is Healthy Connections. So Healthy Connections is a regional HIE in New York. New York has 8 or so HIEs in the state. Healthy Connections reaches all the way from the New Jersey border and Pennsylvania border, all the way up to the Canadian border. So it's a pretty geographically diverse health information exchange. It is on the higher end of what Wendy mentioned. They have over 400 different source systems that were providing clinical documents into their system. They have even more than 400 connections in total, but the vast majority of their connections are actually providing clinical documents as part of what's information is being provided to the Health Information Exchange. And what we actually saw when we started looking at those connections is that it just represents like everybody that's out there in the market. We talk about some of the EHRs that attend HL7 conferences and some of the biggies like Epic and Cerner and Allscripts and several others for it. But when you actually look at the real world usage among health information exchanges, they connect to a wide variety of systems beyond just the big vendors, because even if you've only got 0.5% of market share in the United States, that still might mean you have hundreds of different practices using that electronic health record and are increasingly conforming to these standards because it's required that you can output CCDAs as part of your meaningful use certification, and it's routinely being done today, which is great. I mean, I think it's an accolade, and it's a point of maturity from the standards basis. So what we did, and this is in a research paper that's actually cited right down here at the bottom. After I get off and before we have the Q&A at 11, I'll put both of those in the chat for Zoom and also in the Zulip chat, so everybody can just go directly to the actual full research for it. We sampled 100 documents from 474 sources, and we did this in June of 2020, so last summer. And what we did is we just started asking, what is the data quality? If you were to, forget the way that we used to do primary source verification, not saying that you're not going to do that in the future, but just forget that and say, how would you look at these documents and how would you say, what are the quality of them? What problems do we see? Are they routinely reliable for it? We started asking a whole bunch of questions. We had over 20 different rules that we evaluated as part of Healthy Connections, and asking very basic stuff like, can you actually, once you receive these documents, do they process through software? Can you get all the data out of them? Do patients have valid names? Do they have date of births for it? You don't want to just have the initials of the patients for it. You want to have their full name for it. Does the document name a custodian? Do they have valid dates for problems and immunizations and results and vital signs? And for those of you who've been doing quality measurement for HEDIS, those are really important things to be able to have dates associated with that information, because that's going to be critical to the calculation of the measure. And again, this is only like 6 or 7 of the rules that we had out of over 20 for it. But what we saw is essentially, wow, this is like really high for a lot of these things. Essentially, the data that's in these documents is very valid for a lot of different respects for it. And we're checking this in electronic ways for it. So you can think about this as they're a little bit different than the rules that are in the C-CDA scorecard rubric, but they're rules for it. And we've published the rules that we've used previously that are kind of even a larger set for this as well. But we were seeing really great things in some dimensions. But Wendy mentioned an example. I'll actually talk about that example first at the bottom, and then I'll explain this chart that we actually have up here. 1.2% of all procedures in the procedure section of clinical documents were active or they had a date in the future, which means that your encounters today but the date for the procedure is tomorrow or next week or next month for it. You'd say, well, you know, there were several 100,000 because we sampled over 40,000 documents. There were several 100,000 procedures. You know, is 1.2% a big deal or a small deal? Well, I think it is a meaningful deal. So we have a rule that checks for this. And what you actually see is it's not a random sampling of 1% of procedures across all of the clinical documents, but it was actually for a couple of vendors, it would be 10 or 20% of their procedures. And we actually worked in 2020 with 2 different EHR vendors. I won't call them out on the phone, but we do know who they are because we worked with them, and both of them responded to this, and they actually responded to the exact issue that Wendy mentioned, which is, oh yeah, we allow for open orders to be in the procedure section. And when you go back to them and you look at the definition in the C-CDA of the procedure section, it's clearly meant to be historical. It's not meant to be future or open orders for it. The mood code is tied to what's called EVN or event, something that's already kind of happened for it. And there's a plan of treatment section where you certainly could have open orders for it. And both of those vendors responded by making changes to their EHR to make sure that that happens, which is essentially open but not completed mammographies and colonoscopies should never go in the procedure section. So that was a great thing that kind of came out of this, which is you find things like this, but people respond to this, and people, when they understand the standard, this is just a maturation. This is about making the clinical documents more and more usable for it. The last piece of data that I'll share here, which I did present at the LOINC conference just last week, and had actually very, very positive reviews for this and other things that we were pointing out around LOINC adoption for it. What this is a little chart that actually shows what fraction of LOINC, or sorry, results, the results section of C-CDA had a LOINC code that was a valid LOINC code in the code element of that. And what every dot on here represents is not an individual patient or document. Every dot is a facility. And remember, we sampled 100 clinical documents per facility. So every facility might have thousands of different lab results or results in general for it. Note that results is a pretty big category in C-CDA, which is it's both labs and imaging, and it can have some other stuff in there as well for it. So every dot is a facility, and the colors are different EHRs. So we had some EHRs that were more prevalent and some EHRs that were less prevalent. I haven't said exactly what colors or what EHRs. We know that, but we didn't, again, in this publication, want to call out individual EHRs. What do you see here? Well, as you go across here, you see very big variation. So you have this EHR in blue, and some places only had 10 or 20% of all their results information coded in LOINC, but that same EHR at other places had 80, 90, 100% sometimes. And that held up as you looked at different EHRs. And what we're seeing is that when clinical documents get implemented in the real world, the adoption of things like structured coding and terminologies varies. It's not consistent. This isn't a reflection of the standard. By the way, if you got all this data today on FHIR, I think you'd see the exact same thing. That's a little bit of theorizing, but that's what I believe for it. And if you say, sometimes you want to say, well, this EHR is doing it wrong. Well, if you look at it, if you average these EHRs, which would be the average of the dots here by color, you'd see the average of them is about 50 or 60% on average for it. But the variation by site is larger than the variation from EHR to EHR on average for it. So there's a lot of leeway and play in how people implement these things and how usable this data becomes for it. But I want to also kind of, just end with the note that this isn't necessarily a clinical C-CDA clinical document problem. This is a data problem. This is a data quality concern, but it certainly hampers the ability to do things like quality measurement. Last point, and I'll put this one out there, it's on the Confluence webpage, is that, Wendy mentioned that they weren't looking in the DAV program to do quality measurement. So this is a little bit of outside the purview about what I'm going to say for the DAV program. But we've worked with HIEs, and we actually published a paper, and I wasn't able to do a slide on it because it was just last week, that C-CDAs can be used for quality measurement. And we actually showed that when you longitudinally put these things together from C-CDA and HL7B2, you can measure a lot of important quality measurements, eCQMs, and it works. And with Healthy Connections, we actually saw that those things were often, near national benchmarks for it. So comparable to other ways of being able to do that. So I know know I ran probably just a couple minutes over, but I'll put those things out in the chat, and I'll hand it over to Nance as the next presenter.
Thanks, John. I just wanted to say, that was a good presentation from Wendy and John about, why and what's possible. And now I think with Nance and Michelle, we're gonna get a view of some of the challenges. So having said that, Nance, take it away.
Thank you very much. I will share now. And I have to say that I found myself smiling quite a lot, John, as you talked. Just get myself into slideshow here. Because standards, especially when you mention fire, because I kind of think we're headed down the same challenging road with fire, perhaps magnified several times because it has a little more flexibility. Oh my lordy be, flexibility is not the best thing in standards. So I'm one of the I work very closely in New York State with the health information exchanges, even though John and I have never met. I'm one of the exchanges that has not yet done the DAV program, but I come from an organization that has a very strong philosophical approach about using the data, not just collecting the data, but using the data, and also going through very extensive processes to validate that the data coming into the HIE is representative of the data in the electronic health record. And I'm just going to deviate from my slides for 1 second to add the story that one of our steps in this process is actually to have somebody from the practice looking at their EMR while we are looking at their data in our health information exchange. And we validate patient data. And we were doing one where we said, okay, and the patient temperature was 98.6, or the EMR said the patient temperature was 98.6, and we said, oh no, well, we have 98. Well, the patient temperature was 101.4. We have 101. Come to find out that the outbound file for that EMR was cutting off temperatures at the decimal point. And so we were never getting the values to the right of the decimal point, something we would only have found by going through that extensive panel-to-panel comparison of the data. So it sort of reinforces our sense of good thing we're so careful about this. As John described, we, as an HIE, ingest the data from hundreds of sources. It requires that we be extremely flexible, but also that we really pursue with each of those practices what they're doing. It's our experience that users of a health information exchange are very rarely interested in actually looking at a CCD or a C-CDA. They're much more interested either in point of care data to answer a single question at a time that they are with a patient. And to that end, of course, we found it very useful not to show 1M male, all for A, all the different things that people might use for male, but rather to normalize all of those to something similarly with discharge dispositions and other things where the codes are all over the place. So we bring all of those in and standardize or normalize them so that our users have a consistent vision of the data. And we take data in any form you'll give it to us, from an Excel file to a CCD, because we really want the data. We find ourselves, and it was interesting to be invited to this panel because of this, we find ourselves less focused on the quality measurements than we are focused on helping a practice get to good quality measurements so that they are aware 6 months before their deadline of which of their patients they should be doing outreach to in order to have a better result on their quality measures. And that's very much driven the kind of services that we've built. We have found a lot of challenges working with CCDs. EMRs do get ONC certified, but, and many of these things John was alluding to, when they put the EMR in the practice, the providers are not necessarily aware that if you don't touch button 6 before you touch button 9, then the data is going to go in a different place when it's outbound, when it goes in an outbound feed. And so operational challenges in the way the EMR is implemented in the workflow of the practice are critical to how the data comes out the back end of that machine. And we have found that, I mean, isn't this true in so much of our lives? The rule is that there's always an exception. And I don't mean to pick on Practice Fusion, because I'm a fan of theirs in many ways, but take 10 plus sites of Practice Fusion, and the diagnosis is only in the problem section. But then you get a few more. Oops, sorry, didn't mean to do that. You get a few more, and it's in the encounter summary. Now, why are two Practice Fusion sites different from all the other Practice Fusion sites I've worked with before? I don't know. It's because the rule is that there's always an exception. We have also found discrepancies between what's in the human readable section of the CCD and what's in the coded section. Now, an ETL process, extract, transform, and load process, which is what we use to bring data from all our multiple sources into our aggregated databases, can't parse, or doesn't parse. It could if we worked hard enough at it. It doesn't parse the human readable, it's parsing the coded section. But when my staff are doing data verification and they happen to look and see, oh my goodness, the human readable has stuff in it that the coded didn't, or vice versa. Well, vice versa doesn't matter as much because I'm only getting what's in the coded section. So when there were things in the human readable that weren't included in the coded, my community lost. We still find problems with the encompassing encounter. This is only in v2.1, so not everybody is up to that standard yet. It helps a little bit, so there's some movement in the right direction. This slide, and I'm going to try to move a little more quickly. This slide just points to some of the things that we are looking for as discrete data elements, because that really is one of my critical points to press, is that ultimately it is discrete data elements that we need to be able to use. So we have 4 different flows now that we follow. Each one of these allows us to start getting at the discrete data in the CCD, and then we have to modify modify these as we go along. And we sort of imagine that as we keep moving through this, and John may have some experience with this already, we'll have many more than 4 master flows. We'll have 20 or 30 master flows, and then our lives will be a little bit easier. I wanted to close on what I think would help. And that, what I think would help, speaks to the whole world of technical specifications and standards that I am the user of, but have never been the promulgator of. And as a user, I would argue for much greater specificity and leaving less options of variability when the product is implemented and modified for the workflow of a local place. We need to ensure also that use cases help to establish those standard implementations so that an organization implementing understands why they're doing what they're doing and what they should do in this case versus what they should do in that case, depending upon what the challenges of their practice might be. I think we also need in our tech specs to be much more careful about integrating true clinical detail, like temperatures do have values to the right of the decimal point. And as supervisors of standards, I think it would be really helpful if there were audits done to make sure that implementations do really match certification specs, because I think what you also see in John's point picture of all those data points all over the place is that you can say it's certified, but in practice, 50% of the time, it won't be implemented in a way that garners the effect of that certification. And circling right around to where I started, one of my biggest fears at the moment is fire. And the fact that the variations in fire implementation are going to make this fantastically flexible tool and spec very, very difficult for those of us who are actually working, getting relevant information out of all the data. And with that, I'm going to turn it over to Rachel and let her finish up our panel presentation. Thank you.
Hi, I'm going to go ahead and share my screen. Get the right one. Okay. Can everyone see my screen?
Yep.
Looks good.
Okay, excellent. Okay, so I'm Rachel Fernandez with Dynamic Health IT. I've been attending IAT Implementation-A-Thon since inception and have seen C-CDA grow and change and continue to be used successively across the industry. Dynamic Health IT, just so a little bit of history of where I come from, we've started certification in when 2011 occurred. We were doing HL7, 2.1, and then CCD came about, and C32, then quality and QRDA 1s and QRDA 3s. So our piece of this is we sit between the EHR vendor and the HIE and anyone else that needs to get a CCDA via direct or XDR, any protocol available. So we're seeing the troubles of the EHR to get the data out and into the formats needed. We're seeing the workflows that dictate that, well, that just doesn't happen in our environment. But the other thing that we offer is both sides of the spectrum. We create CCDs and QRDA 1s for quality and are the interoperability piece for over 50 EHR systems. Okay, so with ONC requirements easing the exchange of direct protocol and XDR transfer to HIEs, we are seeing that CCDAs are being used in the masses and they're available, easily available at this point. Up until recently, Dynamic Health IT basically refused to use a CCDA for quality measures. We actually did not certify with HEDIS from the perspective of they wanted our CCD to meet the measures. We were trying to certify 93 measures and it just wasn't going to happen. We could probably do 7 really good, 25 kind of well. So we didn't take that approach at the time. Well, what's changed? We're taking the approach, and only because of demand and the need to ensure that we are HEDIS certified, the need to ensure that we can communicate to the HIE what they need. Those things have brought us to a position where our clinicians are saying, well, can't you use my CCDA? I can get this out in a batch. I can give you as many as you need. It has all the data in it you could possibly need to use. Quite frustrating because they don't understand why it wouldn't have all the data in it that it needs if it's a certified CCDA. So we are going to march with the group and stomp our feet while we're doing it is what I think is going to happen here. So the MIMS measures have become more complex, and with that there is a need for more data to be provided for just the simple MIMS measures, formerly known as PQRS measures. And the eCQM data handles a lot of those needs. And that format for that is also a requirement. So with ONC's newest push to put more data in the CCDA, get the clinical notes out, create more documents, there are more ways to get the data, a discharge summary or a progress note, or any of the new documents, not new in the EHR world, but new in creating a standard document. There's more data coming to us, but it's just more of the same is what we're finding. So DHIT is going to request that there's some consideration there that we're not just dumping more data into these CCDAs. So with that, we've learned that you can't just use the CCDA, as Wendy and John and Nance have mentioned. You need to get the data other ways. So we're taking the CCDA, starting there, moving into KIT and a ORU feed if necessary, and then diving into the database, which is what we do all the time, working with EHRs. They're writing data extractions to give us the data needed. But why? Why aren't we just using the QRDA is my question. Like, there is a document. HL7 has covered this. There is a CDA 2.0 document that is very specific for data required for calculating quality measures. It handles mood codes. It handles the things that we just don't get in a CCD. It's accepted by all reporting programs and can be used by registries and other systems. Recently, there's been a push that I've been seeing, comments to information blocking, comments to certification. Why do we have to produce a QRDA 1 if all they need is a QRDA 3? Well, I'm telling you why. EHR vendors are giving QRDA 3 out to physicians and saying, here's your data, this is your aggregate information, this is where you stand. And the physician says, well, no, I really do think I'm recording that properly, and I know I'm doing that procedure. What's the problem? So we go into the problems. What we've seen recently, just for this reporting period, is we were working with an EHR vendor and not an EHR vendor, I'm sorry, actually working directly with the practice and the provider. And he said, here's all my CCDs, just please, we're in a rush, can you calculate this for us? Well, as a registry, that's one of our roles, we were able to take the data, start with the C-CDA, and this is some of the things we found. The encounter section had a very generic code, CPT code 99211, which means there's an office visit. And we're like, well, where is your specific visit? Because they said, we're definitely recording it. Well, we got on the phone with the EHR vendor and they said, oh, that's going to be in the plan of treatment data. You're going to need to look there. Well, if you know anything about plan of treatment, and if you don't, plan of treatment tends to be just text, no coded values, that a machine, nothing machine readable. So that became a problem. So what did we do there? We actually found the encounters and started to parse that very specific field the way that EHR vendor was providing it, which was in the prior screen on the right-hand side highlighted. The next thing we found was that, well, and we knew this, but, and you'll find this as well, is the author and doc.gov sections that are required for submission to any program, just that data is not formatted properly in the CCDA sometimes it's in different sections. And now we have a new part of a CCDA that, you know, we have performer, we have author, we have doc.gov, we have data enter. There's so many different sections of that CCDA that you can put things like the organization ID, but it may not be a TIN number. It may just be some random number that that organization has defined themselves as. The NPI for the provider may not be in that document. There is very specific program identifiers that you may not find in that CCDA either, things for the various different programs I have listed here. There are CPC plus identifiers specific to the location that's not in the CCD. There's more. Some of these were already covered by Wendy. John, great job in explaining some of the issues, as well as Nance on things that were not seen. Some things that weren't mentioned, the OIDs and the codes for quality measures are tightly constrained so that those OIDs are very specific to the codes that are required for the quality data. You're going to have a mismatch there, and we talk about it all the time in our CDA meetings about the disconnect and how to align those quality measures tightly with the OIDs and the value sets. We found that results, and this was already covered, but you know, result code HBA1C seems good to me. I know exactly what it is, but it's not the LOINC code. So if it's not the LOINC code, then I can't use it. But it makes sense to the person reading the document that that's totally a HBA1C. Pay-a-dater, big problem here. Quality measures require pay-a-dater. Not only does it require pay-a-dater, but it requires that you categorize your pay-a-data in 4 different categories. With that being said, there's 80 different data elements, at least it might be 88, C-CDA in the CDA, sorry, document that you could put in your CCD for payer data. Love to see how that's going to be nationally recognized identifiers for insurance companies. There's no national registry for that, so that's another problem. So with that being said, payer data can be included, but it is going to be another area of problem in the CCD if we don't give some recommendations about how and what to do there for identifiers. The last thing I think we kind of recovered, I believe Wendy covered this in the medication dispense, dispense medication. I have an example on the right-hand side of the screen. The use bys and the mood codes and the information needed there is rarely ever used, and this is an example of it being used And John mentioned, I think you're not finding this information. So with that said, that's my last slide, but I just want to follow up by, it's not a lost cause. I do think that ONC can help us along the way. I do think that USCDI V1, 2, 3 should be able to help us get where we need to be. If we're going to have to use these documents, my recommendation is start with there. That's your starting point. It's not your ending point, and you're not going to get where you need to be if you're counting on CCDs to make that happen at this point. And I'm on the CDA management team with the group that just spoke, and I would love to, help pursue this goal of having one document. I just don't think that one document is ideal. So start asking for the QRDA ones, and hold people accountable for providing those QRDA ones. Okay, that's it. I think we have a break now, right?
Everybody write down your questions so you don't forget them while you go on break.
Yeah.